On behalf of Professor Xiao
Charlie.
Liangchen, it's my great honor to perform two live coronary intervention cases from our center, Nanjing First Hospital. So please, Dr. Ge, introduce your case.
This is a 69-year-old male. He was admitted into our hospital 40 days ago due to acute inferior myocardial infarction. His risk factors include hypertension and type 2 diabetes. Lab examination shows eGFR is 62. His BNP is normal. ECG shows pathological Q waves in leads 2, 3, and IVF. Echo finds abnormal inferior wall motion and left ventricular ejection fraction 52%. This time, he was diagnosed as unstable angina and old MI. 40 days ago, this patient underwent primary PCI due to acute myocardial infarction, and the two drug-eluting stents were deployed in right coronary artery. This is the final result. It's good. Today, the target lesion is left coronary artery. From AP coronary view and spider view, we could find diffuse severe stenosis from distal left main to middle LAD, involving left circumflex and first diagonal with severe calcification. There are two bifurcation lesions, distal left main bifurcation and LAD first diagonal bifurcation. According to definition criteria, a complex bifurcation lesion is defined as any one major criterion plus any two minor criteria. Definition 2 trial demonstrated that two-stent technique, especially DK crush, is associated with a lower risk of target lesion failure compared with provisional stenting during 1 year follow-up and 3 year follow-up after PCI. So today, the syntax score for the patient is 29. We also calculate syntax 2 score. 4-year mortality for PCI is 7.9%. 4-year mortality for CABG is 11.8%. According to definition criteria, distal left main bifurcation belongs to simple bifurcation. LAD first diagonal bifurcation belongs to complex bifurcation lesion. So today our strategy is IVUS-guided PCI according to ultimate trial. Based on the findings of IVUS, we'll maybe choose ROTA, IVL, or others for severe calcification. We also plan to perform DK crush for complex LAD first diagonal bifurcation and the provisional stenting for distal left main bifurcation.
Let me summarize this case 40 days ago because the inferior MI we performed the primary MPCI for the right coronary artery. And today is stage 2 PCI for left coronary artery. And from today's angiogram, can see the two stent is panned very well, and TIMI flow is great. Okay, the left coronary angiogram, we can see the distal left main bifurcation involves the distal left main and the circumflex and the LD. Also, we can see the bifurcation, LD and to diagonal one, and we can see severe calcification from the distal left main to the middle LD.
Today's baseline left coronary angiogram, actually you can see there is two bifurcation. One is the distal left main bifurcation, another is the LAD diagonal bifurcation. From this spider view, we can see clearly distinguished the orifice of the diagonal and the orifice of the circumflex is very critical. However, the lesion length of the diagonal is quite long, just as you mentioned in the case introduction. It's a typical definition defined complex bifurcation lesions angiographically. However, for the distal left main bifurcation, although the narrowing of the circumflex osmium is still critical, but the lesion length is not so long, less than 10 millimeter. So from the angiography, I think it's a simple bifurcation. So I fully agree. Yeah, you just mentioned for these two bifurcation, it's individual decision making. For circumflex, I think for distal left main, I think a simple bifurcation provisional standing. For LAD diagonal, according to the definition criteria, it's a typical complex bifurcation lesions. So according to the definition, two trials, so two-stent technique, especially a DK crush, superior to provisional stenting in terms of a 1 year or 3 year clinical follow-up.
So But another issue is severe calcification from the distal left main to the middle LD. So, what's the strategy for this calcification? Ruta or species or others, probably intravascular imaging give us some important information to guide us to use this tool. Dr. Pan, can you show the IVUS imaging?
Okay, let me show the IVUS imaging. The first one we check IVUS from the distal LAD to left main. And here we can see this is this point is a distal LAD, and here the vessel is not normal. Then go back, we can see eccentric plaque. Then go on pull back, we can see the plaque area is more and more larger. And here this point is a distal plaque minimal lumen area, and the area is about 3.5 millimeters square. And the plaque burden is just 60%. This point is the minimal lumen area. And here the area is just 1.5 millimeters square, and the plaque burden is more than 86%. Then go and pull back. Here, this is a proximal LAD. Then go and pull back, we can see the calcification angle is not more than 180 degrees. Then go on here, we can see the guide wire. This is a diagonal. The diagonal we are drawing LAD. And here we can see the calcification angle is more than 300 degrees. And this point is the ostium LAD. Here the area is about 6.1 millimeters square, and the plaque burden is about 65%. Then go and pull back, this is the POC, and this is the distal left main. And here the distal left main area is about 5.3 millimeters square, and the plaque burden is more than 74%. And here we can see calcified plaque, but the calcification angle is about 180 degrees. Then go and pull back, this is the body left main. And here the body left main vessel diameter about 5.5 millimeter. The second round we check IVUS from the diagonal to ostium diagonal. And here we can see the diagonal vessel is not normal, and the vessel diameter about 3.3 millimeter. Then go and pull back, we can see eccentric plaque, and the plaque is more and more, plaque area is more and more larger. Then go and pull back, this is the ostium diagonal. The ostium diagonal area is about 2.2 millimeters square, and the plaque burden is more than 75. And the narrowness from the distal landing route to ostium diagonal is about 13 millimeter.
Thank you, Dr. Pan. Thank you introductions. I've seen more information. Actually, based on the IVUS information, we can precisely define the lesion length and define the landing zone and also the stand size. But the most important thing is about the calcification, because from the angiographically, it's a typical severe calcification, and also the IVUS show at the proximal LAD, especially just before the orifice of the first diagonal, it's a circle superficial calcification. From this point, I think, Dr. Ger, what's your strategy for this severe circle and superficial calcification?
From this angle, can see the middle LD is very significant stenosis, but from IVUS, we can see calcification is mild, and the calcification all focused on proximal LD. So I think the T-wave SPC maybe is a great choice for this calcification. So we already for this T-wave is the Chinese chemistry T-wave, and I want to do this for this calcification.
Actually, you can see there is a two wire. One wire is in the LAD, another is in the diagonal. This case, we use a femoral approach with a 7 French EBU 3.75 guiding cassette to get strong support. Yeah, I think it's good. Yeah. So, Doctor, can you introduce the special teaching point for the IVL therapy for these particular calcification lesions?
Yeah, use T wave, similar to the shock wave from the other country. But T wave is a Chinese domestic device. Also, we use this size. Choose the size is important for.
Okay, we position the balloon just at the bifurcation site. So we inflated the balloon at full atmosphere. Then we started the first round. Now the TV balloon started to work. So automatically the machine have start to give the give the shockwave energy.
This first round is done, and the inflation is balloon 6 atmosphere, and we can check balloon to show the
The
expansion.
patient hemodynamic now is stable.
Yes.
Considering it's older MI, inferior MI cases, at this time we inflated the LED, I think the patient, that there will be some risk. So at this time we should pay attention to the hemodynamic. Okay, BP is good, BP is up. Yeah, a small test. I think maybe need a little distal advanced balloon. What do you think, Dr. Ge?
Yeah, I think.
We should
But
take-
from this angel, probably all cups are consumed. Already cup.
Okay, here is good. I think it's good.
Okay.
We can up the balloon and do the lithotherapy
Okay,
again.
it's great.
Yeah,
It's great.
it's
Okay.
now it's good.
Mm.
So I think after IVUS check, we will perform decay crush
Yes.
for this particular LED diagonal complex bifurcation lesions.
Yeah, from the IVUS we can see media dissection, and here we can see the guide wire. This is the LED and the diagonal bifurcation.
I think we have get a nicer effect with T-wave IVL therapy. We have cracked the superficial calcification.
Finish.
It's
Maybe
okay.
here this is a crack.
There's a crack.
Yeah, you see clearly. Yeah.
Mm.
This is a distal. This is a middle LED just before the diagonal. So after lesion prepare the ostial diagonal, then we will use 2.75 by 15 jacket-loading stent to treat the diagonal lesions. You can see it's a critical lesion of a middle LED. There's slip.
Sorry.
Yeah, be careful.
Slip.
Just gradually. Yeah, here, that's the right position, gradually. Still, I think we need more distal to do the lesion prepare, I think.
Mm.
What do you think? We didn't,
Okay.
you see? We shouldn't
Yeah.
need
Two.
slowly. Yeah, slowly.
3, 4,
Be careful. 6.
5, 6,
8, 10,
7, 8,
10.
9, 10.
I think 12 is enough.
Oh,
Yeah.
yes. Okay.
Okay, good. First stand, according to the IVUS imaging, we will choose the 30 by 33 jacket-loading stand. Put a wire more distal.
Yes.
30 by 33 jacket-loading stand, thermal jacket-loading stand for the middle LED. To avoid the orifice of the diagonal, will you go to the aerial cranial? Yeah. From the aerial cranial, we can distinguish the bifurcation LED and diagonal.
Yeah.
What do you think?
Yeah.
Still go to the spider view to recheck the position.
Okay. It's on the diagonal. Okay.
Yeah, it's good.
Okay, yeah.
How about the distal landing zone? Check. I think we still need to go to the distal landing zone. Yeah. Because from the spider view, actually we can go more distal. Yeah. Test please. For longer stem, we need a long time inflation to achieve the fully stem expansion. So at least 15 seconds. Yeah. Otherwise, the stem will be deployed. Maybe we should pull back a little and do the stem balloon post dilation. Yeah. So
And
what's the next step, Dr. Ge?
Is to want to put the stem in the second the diagonal.
So this is a decay crush for the LED and diagonal.
Yes.
Complex bifurcation. The first step of decay crush is a side branch standing. So we choose a 2.75 by 15 jacket-loading stand. For diagonal with a minimal protruding into the LED. What's the balloon for the crush? What's the balloon size?
Based on the IVUS to choose the 3.5
Okay.
non-compliant balloon
Okay.
to embed the LED to crush. Oh, sorry.
For these bifurcation lesions, it's actually this is often phenomenon, the wire crossover wrapping, so which will increase the resistance when advance the device. So and I think another a good option is to use something like a dual lumen cassette to facilitate the wire rewiring to the side branch to avoid the wire wrapping. Actually, you can see now the Dr. Ge advanced the side branch stand. This step is quite important. You should use a proper sizing balloon to fully crush the stand segment protruding into the main vessel.
12, 14, 16, 18.
I think we should check the. Okay.
Section. Okay. Go to here and rewire to the diagonal.
Okay. So after successfully balloon crush step, we'll do the first rewiring to the side branch from the proximal cell. We will use a third wire. Is there a dissection? I think.
No.
No.
Yeah,
Okay.
no. It's
Because you see the wire is separated. What do you think? It's okay.
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 Yeah.
Good. If there's still resistance, I think we should check the IVUS to see what happened. It's a proximal cell. I think it's a right cell. What do you think?
Proximal cell, very proximal.
Proximal cell.
Yeah, just one stand.
You see, still there is some resistance.
Yes.
So we will use a serial balloon in the mid LED to do the angle balloon. Yeah. Still, you can see two balloon is quite a lot of resistance. Yeah.
We use 1.5.
Yeah. It's a challenging case, especially for calcification lesion, bifurcation lesion. So sometimes we will have this phenomena. So we should use a smaller balloon to cross the stand struct into the diagonal. So you can see we successfully cross the 1.5 balloon.
Okay.
Still use a 2.0 balloon.
2.0, yes. 2.0 balloon.
I think Dr. Ye has already performed the case